Hi, this is Elliot Fishman, and welcome to part 4 in our talk on challenges and diagnosis of the spleen. And I'm going to start up with basically what ends up being 3 tumors that occur in the spleen, but the only way we typically make the diagnosis is by the pathology. Littoral cell splenic angiomas are benign lesions. They're vascular tumors arising from the cells lining the splenic red pulp, hence the name littoral cells. They're rare vascular tumors discovered either as an incidental finding or in a patient with abdominal pain. Most of the cases I've seen, which isn't all that many, were incidental findings. The gross appearance of the spleen can be slight to moderately enlarged, with a cross-section showing widened splenic trabeculae and more commonly multifocal than a solitary nodule. The littoral cell tumors, again, this incidental finding, but sometimes you can palpate splenomegaly, and there are clinical features, anemia, thrombocytopenia, hepatitis, cirrhosis, but those are all going to be extremely rare. The differential is other vascular lesions, hemangioma, lymphangioma, hamartoma. Angiosarcoma is a vascular lesion to at least mention, but littoral cell tumors don't have the vascularity of an angiosarcoma. Again, diagnosis is made on histopathology and immunophenotyping, and imaging studies have not been very helpful. And that's a good way of looking at it. In part, there aren't really specific findings, and in part, the tumors are so rare, no one sits around saying, well, I looked at 300 cases, and here's some really subtle finding I've seen. Here's an example, dominant cystic lesion in the spleen with additional cystic lesions. The one we can see has minimal rim enhancement. Even the larger one here does as well. There's no splenomegaly, there's no adenopathy. Again, you could say hamartoma, multiple hemangiomas. Those would be very reasonable. This doesn't look like cysts because it's not as sharply defined as a cyst would be. And again, multiple lesions. When you do the differential, littoral cell is one of the possibilities. Another finding, or another diagnosis, inflammatory pseudotumor. Inflammatory pseudotumors occur in many different organs. In the spleen, it's again very rare. Usually middle-aged or older patients, can be associated with Epstein-Barr virus infection. Patients can have a range of presentations from asymptomatic to left upper quadrant pain to epigastric pain. But the truth is, this article by Lou makes the point, it's a rare benign process with non-specific CT features, and the MR features and ultrasound and PET features are no better. Typically a hypodense mass, occasionally with some delayed enhancement. Here's an example. Look at pushing the stomach. You know, lymphoma to me is a very good thought here. Lymphoproliferative disease, something infiltrating the spleen, is really my favorite diagnosis. Here it is again on the coronal 3D views. Big time mass effect, pushing on the stomach, but inflammatory pseudotumor, again, here it is with the cinematic. That's the diagnosis. But the way you know the diagnosis is because the patient had a splenectomy. We described it as a mass, and this mass was solid, so we were concerned it could be a malignancy. Could it be an atypical hamartoma, a really strange hemangioma, littoral cell tumor? It's a mass, it's obvious, but it's really large, and it is concerning to all of us. And so we were able to make the right diagnosis in this case. Really nice example. And the right diagnosis is do a splenectomy, and then you had the answer. The third tumor is SANT, sclerosing angiomatoid nodular transformation of the spleen. Usually an incidental finding, though occasionally abdominal pain. The spleen is top normal in size, rarely enlarged, and its benign course and splenectomy is curative. Again, the challenge is we don't see very many SANTs. Classic appearance people describe in this one article by Kim: peripheral rim enhancement with radiating bands of progressive centripetal enhancement, described as a spoke wheel appearance. But again, not every lesion has that appearance. Often they're just solid masses. Here's a good example of one in the spleen. With a history of fever, this could be an abscess. Could this be lymphoma? Could this be hemangioma? Could this be a littoral cell tumor? Could this be a pseudotumor? All of those are definitely possibilities. And again, the diagnosis is really impossible to make. It is not routinely possible to make a prospective diagnosis based on the imaging features alone. Moreover, it may not be possible to exclude malignancy based on the imaging features, and needle biopsy or splenectomy may be required in certain cases. And that's an article we wrote, and at the end of the day, those lesions will be getting splenectomies. So those are 3 lesions you can use if you get a quiz during conference. If you're giving a differential of a very unusual splenic lesion, but again, being specific for any of those lesions is impossible. So let's look at now splenic malignancies. We talk about primary tumors like lymphoma and angiosarcoma, and then we talk about metastatic disease. So what should we start with? Well, when you think about malignancies in the spleen, metastases are common, but patients with Mets often will have metastases to the liver and adrenal glands. Things like melanoma, renal cell are distinct possibilities. Primary tumors, again, are unusual: lymphoma, angiosarcoma, which is very rare. Angiosarcomas typically are necrotic. They're very vascular. Remember, we spoke about could they look like hemangiomas? And we said a little bit because it's usually more aggressive looking enhancement, doesn't have the peripheral to central filling in, and often it's multiple lesions. Primary splenic angiosarcomas occur in older patients, high mortality rate, and it's also one of the underlying causes for spontaneous rupture of the spleen in up to 30% of cases. They can be solitary, though most of the ones that I do see are going to be multiple. Its enhancement is usually centripetal and heterogeneous, with up to 70% of cases or more presenting with Mets. And the Mets will go to liver, lung, adrenal, bones, and lymphatics. So again, an aggressive tumor. Here's a good example: patient with abdominal pain, ascites. But look at the liver, multiple vascular liver lesions. These do not have the appearance of hemangiomas. They could be metastases from renal cell, but there was no history of renal cell carcinoma. When I see multiple vascular liver lesions like this, which are kind of amorphous and mottled, you got to be thinking about angiosarcoma. And that's what this was. Again, a rare tumor. In general, angiosarcomas are rapidly proliferating, highly infiltrative anaplastic cells that tend to occur locally, spread widely, and have an increased rate of lymph node and systemic metastasis. These are a really aggressive tumor. In this one article on angiosarcoma, 12 patients, that's a lot of patients. Most common finding was an enlarged spleen with heterogeneous complex mass or masses that almost completely replaced the spleen. And again, these lesions were typically vascular. So multiple vascular lesions or just extensive vascular infiltration of the spleen, you got to think about angiosarc. We then talk about metastasis. You can have involvement of the spleen by direct extension, most commonly pancreatic carcinoma, tail of pancreas lesions to be specific. You can have a malignancy of the upper pole of the left kidney, gets large enough, can involve the spleen, and also tumors of the splenic flexure of the colon can directly involve the spleen. I've occasionally seen a jejunal tumor, but then the tumors are really large and really aggressive and essentially spreading everywhere. Splenic metastasis can occur with widespread disease and parenchymal diseases caused by hematogenous dissemination. And again, most common primary tumors include melanoma, breast, lung, ovary, stomach, and prostate. And we've mentioned that before. And melanoma is one that I see most commonly, giving large metastasis and multiple metastasis. Again, at CT, splenic mets present as hypodense lesions typically. Unless the primary is renal cell, then it's typically vascular. Their appearance can vary based on the primary tumor, but typically they're hypodense and fairly well defined. Here's an example of ovarian cancer metastatic to the spleen, multiple lesions essentially infiltrating the spleen. Nicely shown here, and you can see extension going beyond the spleen into the stomach. Here's metastasis from renal cell carcinoma. The metastases are vascular. There's also a left adrenal lesion. Here's some evidence of lung metastasis, as well as these multiple vascular lesions. When I see vascular splenic lesions and I had no history, hemangioma, angiosarcoma, metastasis. But here, with the right nephrectomy and the multiple lesions and the lung findings, it's a lot easier to be specific that this is going to be metastatic renal cell carcinoma. Neuroendocrine tumors can also give vascular metastasis. Neuroendocrine tumors, when they metastasize to liver or spleen, can cause spontaneous rupture of the organs. You can see here lung mets and extensive splenic involvement in this patient, and there's also evidence of liver metastasis. Here's an example of melanoma. Remember how we talk about melanoma involves liver and spleen, can be confused with sarcoid, can be confused with lymphoma. Here the spleen is not enlarged, but has multiple lesions, probably replacing 80% of the volume of the spleen, and really extensive disease also in the liver. Again, very nicely shown on the venous phase imaging. Here it is on the cinematic rendering. So just a really nice example of the extent of disease. Again, if I saw this case, no history, I would say metastasis, I would say lymphoma, I would say sarcoidosis. I mentioned about adjacent tumors a few moments ago. Here's the classic tail of pancreas mass invading the spleen. This is the reason typically when you do a distal pancreatectomy, you will take the spleen as well. The other reason, of course, is when you do a distal pancreatectomy and leave the spleen, it's not uncommon to get post-operative complications. Now, what other primary tumor can we think about? And that's going to be lymphoma. Primary splenic lymphoma is the most common primary tumor of the spleen. It's rare. It's up to 2% of all lymphomas. It's usually non-Hodgkin's B-cell type. We also see secondary splenic lymphoma, and that's common in both Hodgkin's and non-Hodgkin's lymphoma. And with these cases, up to 25% of patients have splenic involvement, but they also have bulky nodes. They also have liver involvement. Lymphoma is the most common malignancy of the spleen, either primary or part of diffuse systemic disease. So again, it's rare to be only involving the spleen. It's much more common to involve spleen and liver and nodes, and the chest perhaps be part of a systemic manifestation of the disease process. Here's a nice example. Spleen is minimally enlarged, but there are multiple low-density splenic lesions. Here's more of an infiltration of the spleen. You could call this multiple small lesions or diffuse infiltration. Diffuse infiltration by B-cell lymphoma is a common appearance. The spleen is enlarged and diffuse infiltration is nicely present. You could see the appearance is minimally different as you look at arterial and venous phase imaging, and the cinematic rendering, which is really good at texture mapping, shows you very nicely that infiltration of the spleen diffusely and that the entire spleen is involved by lymphoma. And here's just a nice side-by-side correlation of the axial images and the cinematic rendering. Another example, several masses in the spleen. The spleen is a little bit large. There are also paraortic nodes and nodes near the porta hepatis. Again, low density. These lesions are typically not vascular. And again, seeing those paraortic nodes and the splenic lesion allows you to put together the diagnosis of lymphoma. In theory, if I had to give a number 2 diagnosis, I would say melanoma. Remember, melanoma can involve the spleen. We spoke about that. Melanoma can give nodes. Melanoma can give adrenal masses. Melanoma can give liver masses. Usually I'm going, and I'll be correct with lymphoma, but every once in a while you got to be thinking about melanoma. And here's just nice 3D coronal views showing you the multiple extensive involvement of the spleen, as well as the extensive involvement of the paraortic region, particularly on the right side. Another example here where you see large masses in the spleen, and as you scan downward, the patient also has a large pancreatic mass. You could say, boy, this looks like a pancreatic cancer, but there's no dilated ducts, and pancreatic cancer would not explain this tail of pancreas, which looked normal and in the spleen was abnormal. If you had a splenic lesion and a tail of pancreas lesion, that's easy. That's typically pancreatic adenocarcinoma. But here, head of pancreas mass, splenic mass, that was a case of lymphoma. Another example, B-cell lymphoma involving the liver and spleen and adenopathy. Again, just like I showed you some infiltration of the spleen a few moments ago, infiltration of the liver can look very similar. And you also see the extensive adenopathy in those cases. And again, this patient also has large pleural effusions, particularly on the right side, pushing down the right hemidiaphragm. Now, I want to speak to you a little bit more about infiltration of the spleen and some things you should consider when you see a case like this. Now, here you can think about, and this was CLL, big spleen diffuse infiltration, but there's other things you need to think about. So let's do this. Let's take a break here. Let's come back for the final part of this talk. And while you're taking a 5-minute break, think about what else the differential diagnosis could be. And I'll see you then. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.